Well, thanks everybody for joining us. I'm really honored to get to introduce Dr. Loyd today. Dr. Loyd is a graduate of the Quillen College of Medicine in East Tennessee State University. He completed his medical residency in internal medicine there. He served as chief of medicine in the Mountain Home VA Medical Center in Johnson City. And recently, and when I got to know Dr. Loyd, he was the medical director and assistant commissioner for substance abuse services for the Tennessee Department of Mental Health and Substance Abuse Services. Over the last 10 years, he's focused on addiction medicine with a special interest in the opioid-dependent pregnant patient. He currently is medical director for Cedar Recovery, Journey Pure at the River, and the Next Door. He's been in recovery from addiction to opioids and benzodiazepines since July 8, 2008. I had the privilege of hearing Dr. Loyd speak several times when he was with the state of Tennessee. And one pivotal talk was when we were in the formative stages of our LifeBridge Physician Wellbeing Program. I was struck by his humor, his humility, and his humanity. And I think that it's extremely important for all of us to acknowledge that all of us need help in our journey in life, and that it's an act of courage and it's an act of grace and an act of wholeness to be able to acknowledge those moments when help is needed. And so Dr. Loyd was a real encouragement to me as we were starting our LifeBridge program, which is available for all physicians in Hamilton County at lifebridgechattanooga.org. Got to get that plug in. So with no further ado, I'm delighted to introduce Dr. Stephen Loyd. Thanks, Dr. Loyd.
Thanks so much, Ray. Just out of my own paranoia, can you hear me okay? Can somebody give me a thumbs up? I've got the little thing over here in my window. Can y'all hear me? Okay, good.
Yes.
Thanks, Edward. I appreciate that. And Ray, thanks for the introduction. And my journey actually goes back to not 2008, but 2004, which is when my life changed. So I'm coming up on 17 years. And so I'm at my clinic this morning in Newport, Tennessee, Cocke County. It's not far from you guys, up 75, just kind of southeast of Knoxville on the North Carolina-Tennessee border. We treat opioid addiction here. And like I said, a really rural place with a lot of limited resources. So I get here early in the morning on the mornings that I'm up here, and it's just a privilege to get to help these folks with their addiction because the resources are so limited. And so as I was driving here, it's about an hour and 15 minutes from where I stayed last night. My home is in the Tri-Cities. I was born and raised in Jonesboro, Tennessee. I went to medical school and did residency in East Tennessee, where I'm from, but I actually live and work in Nashville now. So I have two places and I drive back and forth. As I was driving here this morning, I was thinking about my audience and not anything disparaging to anybody else, but I was so excited about medical students and residents because that's where my story starts. And I would like to speak to you guys just between us just for a moment. Guys, there's about guys and gals, there's about about 18 to 20% of you will have a problem like this sometime in your life. Okay. And you can feel like you're at the end of your rope. And there's a lot of things related to that. There's burnout within the job. There's a lot of reasons that people start to use, and I'm going to talk about that. But I want you to know that if that happens to you, that your life is not over, and to run to help and not away from help. And if you don't know anybody else, or you're scared of the program that Ray talked about, keep my name, stick it in your phone, whatever you do. Because I can tell you there's no circumstance that I won't try to help you. And as I was driving here this morning, I went back, in my mind to when this all started, and I was in residency, and I'll tell you guys about that. I'm so grateful for the opportunities I've been given. That was in 2004. We're in 2021, so I'm coming up on 17 years. And I can't imagine where my life is, because that day that my world crashed, I thought it was over. I thought everything that I'd worked for my entire life, coming out of county high school in rural Northeast Tennessee, Appalachia, and getting through medical school and residency, I felt that it was all over. And I had no idea that it was just the beginning of a journey that was just going to keep climbing and keep climbing. And, it brings me to a combined grand rounds this morning, and at one of our premier hospitals in the state of Tennessee, Erlanger, and one of the premier training programs in our state. And so I'm so grateful for that. And so that's why I really want to impress upon you. If we look at our students and residents, there's some of you that have this problem right now, today. You're sitting there wherever you are, in the hospital, at your apartment, your houses, wherever you are. And I would encourage you to reach out and ask for help, because it's there, and we live in a great state for recovery. So with that said, that's my intro, maybe a little longer than I wanted. But today I'm going to cover with you a lot in the context of my story. And the main thing is that addiction is not a moral failure. So we've got folks on the line here from all different specialties within medicine. We've got administrators, we've got people from the community. And the truth is that all of us are pretty much in the same boat when it comes to understanding addiction. And I hate to burst the med students and residents bubble here, but you all know what I'm getting ready to tell you is true, unless things have drastically changed in medical school and residency. And I don't think they have, because I still teach in them, is that we get very little training, if any at all, on addiction. We get very little training on the proper prescribing of controlled substances for both acute and chronic pain, yet we have a prescription pad and a DEA number. And so I'm going to try to give you some things that you can use in your day-to-day practice. We have the Tennessee Chronic Pain Guidelines that you need to be familiar with. It's actually required for your licensure. Another thing is I'm also on the Tennessee Board of Medical Examiners. So when you guys get your license, my signature will be at the bottom of it. I'm actually the vice president of it. So, but at any rate, when you apply for your license on a 2-year cycle, you've got to have 2 hours of continuing medical education every year around this topic. And so we're trying to help you. There's a lot of things to know about that, but in the context of your office visit, particularly surgeons and people who are inflicting acute pain on people for a short period of time, how do you make that decision about what medication that you're going to write, and for how long a period of time, and for what strength? And I could tell you that you really use the swag method when you're doing that, because you didn't get any training on it for the most part. And your understanding of it's basically from a pharmacology class and from what you learn from your mentors. And not to take anything away from the mentors, but the training is very minimal. The screening questions you ask around addictive potential, if you have any at all, are going to be minimal. I want you to have an understanding of who is at risk to misuse this prescribed controlled substance. And not that you're not going to write it, but I want you to be able to do it in a timely manner, because what you all do, and it's what I did, you use something called the SWAG method. And I don't know if any of y'all are familiar with the SWAG method, but it stands for scientific wild ass guess. And so that's what you do, and it's okay, all right? But I'm going to give you a better idea of that as we go through our talk today, and then I'm going to interweave my own story in there to try to give you a little bit of flavor for it. And Brody, you're first on my Brady Bunch list, and so the patient that I make up today is going to be you, and you're going to be surprised, but I'm actually going to turn you into a pregnant girl, which will be magical. But I got to have somebody. So Brody, you're first on my list, so it'll be you. So let me see here. All right. So when I got out of treatment 17 years ago, like I said, I thought my life was over. And I got started with my addiction during my chief resident year. So I went to undergrad at the University of Tennessee at Knoxville. I worked for about 3 or 4 years after I got out of undergrad before I went back to medical school. So I got through medical school, got through the last year of residency before all this started. But what I didn't realize at the time that it all started is I'd always struggled with alcohol. Right, I never was a daily drinker. I'd never gotten DUIs or anything like that. But to say that I was an unsuccessful drinker is an understatement. When I started, I almost could never stop until I passed out. So I was a blackout drinker, but only intermittently. So I kept telling myself stories about why I didn't have a problem with alcohol. And all of them turned out to really just to be justification, the fact that I didn't want to address the issue. So I'd had that history. So when I got into medical school, I love my classmates. We started medical school in early August of 1995, and still the most impressive bunch of people that I've ever met in my life. And I still love and respect every one of them, and I'm still in contact with a lot of them. But the first day we were introducing ourselves, and people were standing up and telling a little bit about their backgrounds, and I was listening to this. One of my classmates was a test pilot for the stealth bomber. He went to the Naval Academy. He wound up to be an ophthalmologist. But I'm sitting there going, "Oh man, I'm in deep trouble." I went to University of Tennessee in Knoxville. There were times I struggled to barely get out of there. I happened to do decent on the MCAT. I'm in trouble. And so really impressive, but so already the first day I felt unbelievably inadequate when comparing myself to my classmates. Well, the second day of medical school, we had our class elections and they elected me their class president. And I was shocked. I couldn't believe that. I'd only known him for a day pretty much. And I actually served in that capacity all 4 years. And I knew this. I knew I didn't want my classmates to see me drink. I did not want to embarrass them because I was always embarrassing when I drank. So I did not drink all 4 years of med school. I kidded them during that time. The only reason they invited me to the parties because I was married and had a child through school. The only reason they invited me to parties after tests was so I could drive everybody home, which I did. The truth is I didn't want them to see me drink. Well, you all know this in your training. The problem is at the end of that 4 years, we spread to the four corners of the earth to do our residency. And so that happened. So not long after my classmates all went away to their residency locations, I started to drink again. Not much, and I didn't drink to the level that I had in past, but I did pick alcohol back up. So I go through my residency. I'm in my chief resident year at the Mountain Home VA in Johnson City. I've got a lot of responsibilities. I'm actually getting ready to step out into practice. So I've got a lot of nerves going on. Believe it or not, residency is protected. It's your attending's name at the bottom line. There's still a cocoon there with residency. And I'm getting ready to step out into the real world. I took a faculty position at my medical school, which I'd always wanted to do. And so I was excited, but nervous at the same time. So I was driving home from work one day after a long day at the VA, and I pulled up to a red light there in Johnson City. And I clicked open the glove box of my truck, and in there I had some old Norcos, which is hydrocodone, acetaminophen, other trade name would be Vicodin. And I'd thrown them in there from a dental visit months before. And I looked over at those pills, they were blue, and I thought, my patients take this stuff all the time. And, I wonder what it does. And I'd never tried one outside of, athletic injuries when I was in high school and college. And so I broke that Lortab in half, or that Norco in half, which is 2.5 milligrams of hydrocodone. I threw it in my mouth. I lived about 10 minutes away from where I was at the time. And by the time I got home, my life had suddenly improved. Suddenly my relationship with my wife was better. The pressures at work didn't seem so great. My kids behaved better, right? And we all know that that's not true, but that's kind of the salve that hydrocodone gave me that day. And it really, I felt like I'd found a cure for my anxiety and my depression. And first time I said that out loud in a talk, some psychiatrist raised his hands. He says, opioids are not a treatment for anxiety and depression. I was like, I know that. I now have more confidence. Opioids have been used to treat behavioral disorders since the time of Hippocrates. The problem is the addictive potential and what I went through on my journey, because over the next 3.5 years, that 2.5 milligrams of hydrocodone turned into 500 milligrams of OxyContin a day. Now, if you think about that in pill terms, Vicodin, that's 100 Vicodin a day, not a week, not a month, a day. You say, well, there's no way to get there. Absolutely there is. It's called tolerance. And I promise you, with enough access and enough time, that basically anybody can get there. And I had access. I was a medical provider. I was a licensed physician. I had my own DEA numbers. All my buddies are doctors, right? And so I had access. So you can for sure get there. And then what I want to impress upon you is my life was not in the crapper, okay? I was doing really well. My first 3 years in practice, the students at our medical school voted me the best teacher on their internal medicine rotation. 4 weeks or 6 weeks before I got help in rehab and treatment, the graduating medical students that May in 2004 voted me the outstanding teacher of all 4 years of their medical school. We had 200 plus faculty members. I was the top producing internist in our practice. I was working in the outpatient clinics. I was doing hospital ward rotations every other month and teaching medical students, medical residents, pharmacy students, pharmacy residents every day, right? I was in the College of Nursing, so I was teaching nurse practitioners in their training. So I did that every day. And what I'm trying to impress upon you is My job performance didn't slip. I wasn't going downhill, but my personal life was falling apart. I wasn't the husband that I wanted to be. I damn sure wasn't the father that I wanted to be. My life was crumbling. The last thing to go was my job. I had no idea how I got here. I went to bed half the nights praying that I wouldn't die and the other half praying that I would. And so for those of you that are in that circumstance today, you don't have to continue to live like that. If you don't know anybody else, you know me now. And I can promise you this, I'll meet you anytime, anywhere, and I will not judge you, because that's one of the mistakes we make with addiction. We bring this tough love attitude, this 3 strikes and you're out attitude. You've got to want it bad enough. The reason you haven't been successful is you haven't found your bottom. All crap, all crap. I don't care what you've heard, it's all crap. And it kills people. So I'm going to try to give you a little better understanding of addiction within the context of my talk. So when I was sitting in rehab, I remember having a conscious thought that if I can get through this, I knew what I wanted to do for the rest of my life. And I promise you that was early on. That was before I even got out of treatment. And so what happened was that my dad intervened on me. I had no idea that there was any place to get help. Got on the computer, I searched, I found this place called the Tennessee Medical Foundation. The chief medical officer was a guy named Dr. Roland Gray, and they helped doctors who were struggling with burnout, depression, anxiety, mental health disorders, physical disorders, and substance use disorders. And I called them up, and they helped me get into a place in Nashville called CPE, the Center for Professional Excellence. I spent 5 days in the detox unit at Vanderbilt University, the Vanderbilt Institute for Treatment of Addiction. And then I spent 90 days at CPE after that in treatment. And guys, it changed my life. It made me who I am today. And I am so grateful for it. The single best thing that ever happened to me in my life was my addiction. And that's really hard to believe, but it is absolutely true. So when I got out, I wanted to learn all I could about addiction because I knew what I learned in medical school and residency, which wasn't very much. And so I started going to neuroscience conferences. Guys, I'm completely self-taught. I was the drug czar for the state of Tennessee under Governor Bill Haslam. I'm not fellowship trained. I'm reading trained. Journals, meetings, latching on to everybody I could find who knew more than I did about addiction and learning from them. So I've done all of this since residency. And it's really my life's mission. I don't fish. I don't play golf. I don't hunt. I don't have any hobbies. I do addiction. Last night when I laid down, when I was reading addiction medicine before I went to bed. This is what I do. And I just absolutely love it. So I went to all these conferences. I would go to neuroscience conferences, and they would always have some guy up there from Harvard or Yale with these brain graphs talking about ventral tegmental area, amygdala, globus pallidus, putamen, hippocampus. I mean, like basically my neuroanatomy nightmare. And I was thinking, there's no way I'm going to be able to teach that in the real world, right? I wanted to be able to teach it to students. I wanted to be able to teach it to basically anybody. I don't care if you're from Yale or you're from jail. I wanted to be able to teach you addiction. So what you're going to see is what I put together through the years. And everything in it I could reference. I didn't make any of this up. So I try not to have a bunch of words on my slides, so you guys are going to see a bunch of pictures. So this is what I've learned about addiction, and I'm also going to teach you a little bit about prescribing in the context of it. So if you look at addiction, the term that comes up is biopsychosocial model. Now, I'm not a psychiatrist, and for the most part, I hate psychobabble. It makes me want to vomit a little bit in the back of my throat. Okay, so I don't get the biopsychosocial model, but I damn sure understand the slot machine. And y'all are in Hamilton County, so I know you've seen a slot machine. This is what they look like. I'm not talking about the fancy Vegas ones. I'm talking about the ones that are in the mini mart. So when you look at a slot machine, when the 3 sevens come down on the pay line, that's when the money comes out the bottom. Okay, so I look at addiction that way. So I'm going to use Brody as my patient. Brody comes in. Brody has a broken arm. Okay, and we all agree that he's going to need some kind of pain medication for this broken arm over at least a short period of time. So I know that I'm going to have to write Brody an opioid narcotic at some point. Now I'm going to write it for him because he has a broken arm, and that is painful. And my job as a physician is to comfort and heal. All right. So I'm not going to not writing this. I don't care if he has a heroin addiction, but I have to try to risk stratify Brody and what his risk is to misuse this prescribed controlled substance. Because if he gets in trouble with it, I want him running to me, not away from me, so I can help him. All right. So when I'm talking to Brody, I'm going to use the 3 sevens of the biopsychosocial model. The first 7 is the biology, bio, right? 60% of addiction is genetic. It's in your DNA. It's base pairs, right? Double helix stuff. 1 chromosome from mom, 1 from dad. You can't do a darn thing about that. So how do I assess Brody's genetic risk of addiction? Well, I could ask him about his own substance use, right? I could ask him about how much he drinks, or if he's ever struggled in the past. That's always dicey because people are scared. Addiction has been stigmatized. Substance use disorder is stigmatized. So Brody's probably not going to tell me the truth. Now, those of you that work in the hospital and acute medicine know what I'm telling you is right. What's the most you've ever been able to get anybody to admit to drinking? Ever? 2. If you've ever been able to get anybody to admit to drinking more than 2, I'm in awe of you. I don't care if their blood alcohol is 370. They drank 2, right? I had a guy come into VA one night with a blood alcohol of almost 400. He told me he didn't drink any, right? He wouldn't admit to 1. So he must have had an alcohol-producing tumor somewhere, because he was for sure inebriated and his blood alcohol was 400. So it's always dicey whenever you're going that route. So how can I run around that? I can ask Brody about his family history. So when you're getting ready to prescribe an opioid for the first time, ask about family history, because people will tell you about that. Well, my granddad had a problem with alcohol. He actually was sober in AA for 20 years by the time he died. My mom struggled with prescription pills, that kind of thing. When Brody tells me that, Steve, I had a dad that struggled early on in his life with substance use disorder. He actually went to rehab several times before he finally got into recovery, but he did well for 30 years. Brody's first 7 is on the pay line. He has a family history of substance use disorder. He has a 60% genetic chance of developing substance use disorder himself. Okay. So Stephen Loyd, back when I was sitting in front of that liquor store in Johnson City, I come from a family of a long line of addiction. I had no idea. I told you about my previous alcohol use. I had no idea that predisposed me to misuse this medication I was getting ready to put in my mouth. No clue. And I'd been to medical school and almost out of residency in internal medicine. How is that possible, right? It's because we don't teach. We don't train our folks. We look at addiction as a moral failure, and basically we shun people with it. We kick them out of our practices instead of trying to get them help. And guys, that's killing people. We lose about 5 Tennesseans a day to this disease, just with opioids. That's not counting alcohol use disorder, nicotine. This is one of the biggest health problems in the United States, and we understand almost nothing about it, and we do almost nothing to treat it, in all honesty. So I've got Brody there. He tells me about his family history. I look at Stephen Loyd. I've got a long history of substance use disorder in my family. I've lost 4 first cousins to overdose before age 40 in my family tree. So my first 7 was on the pay line as well. Now, the second 7 is the psycho part of the biopsychosocial model. So basically that means what kind of household were we raised in. Guys, none of us came out of a normal household. We all have our stuff, okay? But some people are struggle more than others. They have a history of physical, sexual, and emotional abuse, okay? And when that comes along, that second 7 is on the pay line. So when I'm talking to Brody, I already know he has a family history of substance use disorder. So Brody, tell me what it was like growing up in your house. Well, my mom divorced my dad when I was young. And so, and my mom was with multiple men when I was growing up. And they were physically abusive to her. I used to watch them. We used to watch him hit her, and I had one that was abusive to me. And so now when I hear that history, I know that Brody has a history of physical abuse, okay? And so one of the things that we overlook a lot when we're assessing risk and abuse is we overlook the emotional abuse, because physical and sexual abuse, a lot of people haven't had. And they say, well, I didn't really have any abuse. I grew up in a picture perfect family. But if you dig a little bit, a lot of times you can uncover that emotional abuse where mom and dad were at odds, where the child was left to basically fend for themselves. These are called adverse childhood experiences, ACEs. I'm going to touch on them briefly. We could do hours worth of talks on ACEs, but these are emotional abuse, and you have to dig a little bit deeper. But I would argue that a lot of times the emotional abuse is the worst one of the 3 because it's constant and it's never ending. So for me, Steve Loyd, when I was growing up, I was physically abused by my mother. She abused me and my sister with beatings. I mean, these weren't spankings or discipline, sticks, belts. I mean, basically anything that you could imagine. I was sexually abused by an uncle. It started off with molestation when I was 4 or 5 and ended with at least 2 rapes that I can remember when I was 6 and 7 years old. So both of my 7s are on the pay line. Both of Brody's 7s are on the pay line. Now for Brody, as the physician, I'm getting ready to write in this controlled substance. I have just risk stratified him. he is at increased risk to misuse this prescribed controlled substance. I've got to have a talk with Brody. I've got to let him know that he's at increased risk. I'm going to write him a prescription for 3 days, and I'm going to explain that in just a second, okay? And then I've got to tell him, if you develop an issue with this, you need to come to me and not away from me. I don't want to stigmatize you where you think there's something wrong with you or you think you've got to hide, because when we do that, people can run for a long time. I knew I had a problem in the first 6 months. I ran for nearly 3.5 years. It damn near killed me. Brody is a young guy. I don't want to lose Brody. Okay, so we have to keep that avenue open. So Brody's got both 7s on the pay line. What is the third 7? The third 7 is the social component of the biopsychosocial model. And that's just what is widely available and socially acceptable. Okay, so and I'm getting ready to make it widely available and socially acceptable to Brody, because I'm going to write him a prescription. And he can always just hold that prescription and goes, hey, look, this came from a doctor. I don't have an issue, right? And so that's what happened in the opioid epidemic. We made opioid pain medication, widely accessible, socially acceptable over a wide population who were genetically and traumatically at risk to misuse a controlled substance. And we didn't have any idea what we were doing. The social component of it was fed by the pharmaceutical industry, who fed us the lie that these medications weren't addictive if we were using them to treat real pain, although there was no data to support that. And so the pharmaceutical industry said, if you're using these medications to treat pain, there's less than a 2% chance that your patient will become addicted, which is complete horse crap. And I'm going to show you where that came from. And when you see the pharmaceutical industry losing lawsuits around the opioid epidemic right now, this is the reason, and you're going to understand that by the end of my talk. So I've got to have that talk with Brody. So before we get into that talk with Brody, we've got to understand the difference between dependence and addiction. They're two separate things, okay? You can be dependent without being addicted, and you can be addicted without being dependent, okay? What is dependence? Dependence means when I stop whatever it is, I go through a predictable physiologic withdrawal syndrome, i.e. I get dope sick, and then I get better, okay? That is dependence. Doesn't have anything to do with addiction, okay? Addiction is the continued use despite consequences. So if you're screening somebody for addiction in front of you, you've got all kinds of tools at your disposal. In med school and residency, you learned about the CAGE questions, and you got the audit and the audit C and these personality profiles. There's so many different things you can do, and those things are all good. I don't need any of them, okay? What I do is I look for continued use despite consequences. So if I'm evaluating a physician in front of me for alcohol use disorder, and they're telling me all the reasons that they don't have alcohol use disorder, and I'm shaking my head and I'm listening, and I say, okay, tell me about your relationship with your wife. Well, she left me. Well, why did your wife leave you? Well, she doesn't like how I act when I drink. Okay. Tell me about your kids. Well, my relationship with my kids is strained. Why is that? Well, they don't like how I am when I drink, and I can't go to my grandkids' Little League games. Does the physician in front of me have an alcohol problem? Damn straight he does. Why? Because he has continued use despite consequences. That's why. Everybody on this line today, the most important thing to you, all of you, is your family. And if you continue to use the substance despite losing your family, you have a problem. I don't care what the audit C says, and I don't care what the CAGE says, and I don't care that you don't go through DTs when you stop drinking. That's dependence. Ain't got anything to do with addiction. Okay? Now, what really separates dependence from addiction is the phenomenon of cravings. So I give Brody a pain medication for 3 days. Why am I only going to give it for 3 days? Because at 3 days, that's when the dependence process starts. So if I put Brody on pain medication for 3 days and I abruptly stop it at the end of that 3 days, he's going to start to get a little bit dope sick. He probably is not even going to know what it is, and it's going to pass in a few days, and he'll go on about his life. The truth is, you guys do the same thing. You get patients that you put on pain medication for a short amount of time that call you up afterwards, and they're uncomfortable, and you don't realize they're going through withdrawals. And they are. Now, they'll get through the withdrawals. Does that mean they're addicted? Nope, it means they're dependent. I can do that to the Pope, Jesus Christ, or Elvis. Don't matter. Okay? You have to understand the difference. Now, what separates dependence from addiction? The phenomena of cravings. Brody gets through the little short withdrawal syndrome he has. And 3 months down the road, he develops cravings for that pain pill. And he finds himself going to another doctor, over-exaggerating the pain that he's had from this broken arm, and he winds up getting another prescription. And then he goes to pain clinics. And then he goes to the street, right? The difference between dependence and addiction, guys, is the phenomenon of cravings. Cravings drive relapse. Cravings are lifelong. I've been in recovery almost 17 years. Nothing's been in this body for 17 years. Okay. I still have cravings. Does that make you uncomfortable? Okay. I hope not. I have tools that I learned in recovery. I have things that I do every day that are the reason that I don't go back. Okay. But I still have cravings. Cravings are why people relapse. Cravings separate dependence from addiction. The person with dependence does not develop cravings. Now, let me tell you about the second prescription. Brody comes back in 3 days and he's still got pain in his arm. I'm going to assess it. I'm going to tell him my concerns again. I'm going to try to keep the avenues open for him coming back. But when I write him that second prescription for opioid pain medication, there is a 60% chance that he's still on that medication a year later. I want you guys to think about that. Every single time you write that second prescription, there is a 60% chance that that patient is still on that medication a year later. It may not be coming from you, but they're still going to be on it. That's why the CDC recommends for acute pain, the length of time needs to be 3 days, and that's spot on. That's spot on. Please keep that in your mind. Now, when somebody develops a problem, Brody comes back to me, hey, Dr. Loyd, I was scared to tell you, but I couldn't stop taking those pain pills. I've been to several other doctors. I should actually know that because I'm going to check the controlled substance monitoring data bank. But Brody tells me that he's feeling ashamed. He can't do without it. He's getting dope sick. How do most doctors react to that now? Or they look at the CSMD, the data bank, and they see that Brody's going to 5 doctors and he's going to 3 pharmacies and he's getting drugs off the street. How do most physicians and nurse practitioners and PAs respond to that now? You all know, you can't tell me, they kick them out of their practice. Well, that's not very good because now you just drove the street black market for diverted opioids and you just drove the market for heroin, illicit heroin and fentanyl. The goal here, guys, is to reach out to people with opioid use disorder and help them like somebody helped me. So you understand the difference between dependence and addiction. You now have a way to risk stratify patients before you provide that controlled substance, whether it's an opioid, whether it's a benzodiazepine, and you know the difference between dependence and addiction, and you know what drives relapse, which is the phenomena of cravings. Guys, I love methadone. I love buprenorphine, Suboxone. They are part of a comprehensive treatment program for opioid use disorder. They save lives. They have a 70% mortality benefit. I don't care what you think about it. Used in the proper context, they help people into recovery. Okay. Now, how do they work? They are anti-craving. Cravings are why people relapse. If I can stop you from craving, now we can go to work on that behavioral disorder that's driving your addiction. It's as simple as that. So those of you that ever get interested in addiction medicine, come and work with me. Do a rotation. I'd love to have you, and I promise you it'll change the way you think about people with addiction. Either that or you don't have a heart. And my guess is that most of you have a heart. All right, so let's get into the brain real quick. I'll try to go through it as quickly as possible. 2 areas I want you to concentrate on. Again, when I was going to the neuroscience conferences, they made it so complicated nobody could understand it. I'm going to break the brain down into two things for you. Stop and go. So we're going to talk about stop and go. The first area is where my arrow is. If you can imagine where my 2 fingers meet in the middle of my brain, the midline, right along the corpus callosum. Most of the structures under the corpus callosum are contained in something called the limbic system, the reward system of our brain. It's the part of our brain that gives us pleasure. Okay. I want you to think of it as go. Okay. The other part of our brain I want to talk about is everything in front of this vertical fissure right here, the Sylvian fissure. That's the frontal lobe of our brain. It's stop. Okay. The stop part of our brain has 3 big functions. It gives us insight, judgment, and empathy. That's what that's what your frontal lobe does. As you all know, there's a lot more to it, but for our purposes, 3 things: insight, judgment, empathy. The go part of our brain, the limbic system, is about pleasure. It has 2 big functions. 1, it's responsible for our desire and will to live. 2, it's responsible for our species going forward in time. Think about how strong your desire and will to live is. What would you do to preserve your own life right now? You'd do anything. If we were all in an auditorium at Erlanger and they take that auditorium off, they stop food and water from coming in there. After a long enough period of time, we'd start to eyeball each other. We would drink each other's urine in order to sustain our life and try to keep ourselves hydrated. At some point, we're going to start to eyeball each other to see who's the weakest, because that's the one that's getting ready to get eaten first. That's how strong your desire and will to live is. That is a limbic system function. Okay. Now, When somebody is addicted, the drug that they're addicted to replaces that desire and will to live. And the craving that your limbic system has for that drug is 10 times stronger than the normal person's craving is for food when they're hungry and water when they're thirsty. I want you to think about that for a second. I've heard residents come to me with a plan of somebody who are on high dose opioids, and they're going to tell me how they're going to get them off, and they're always going to slowly taper them. I've never seen it work, not a single time ever. If you've ever had that work, let me know. Never seen it work. And then they say, well, they can just stop. They got to want it bad enough. They can just quit. And every time I hear that, I say, okay, fair enough. I want you to stop eating. And not just for today. I want you to stop eating going forward. Because the deal is that it'll be easier for you to stop eating than it will be for them to stop taking that drug. Guys, I wanted to stop taking pain pills every single day for over 2 years. I used to cry in the mornings because I couldn't do without it. And I wanted to be a dad. I wanted to be a husband. I wanted to be a better doctor. It didn't have anything to do with wanting it. I couldn't quit. My craving for it was stronger than my cravings for food. I weighed 170 pounds when I went to treatment because I didn't eat. Okay, you've got to realize what you're up against. And when you tell your patients, oh, just put this down, it's not going to work. Okay, so stop doing that. Let's do things that work. So now you know 10 times stronger than your cravings are for food when you're hungry and water when you're thirsty. The other thing that happens in your limbic system is it's responsible for your desire and your will to live. The things that lead to that had better feel good or you won't do them. Does it feel good when you eat? Yes. Does it feel good when you have sex? Yes. If eating made you feel bad and sick, and sex had made you feel bad and sick, you'd stop eating it and our species wouldn't go forward in time. So every time you eat or every time you have sex, here's what happens. In your brain, in the limbic system, the go system of your brain, your body makes its own heroin, it makes its own morphine, it makes its own oxycodone. They're called endorphins and enkephalins. Those endorphins and enkephalins are released, attached to the opioid receptors, leads to the downstream release of dopamine. And all you guys love dopamine. Makes you fat, happy, and satisfied. Okay? And then it's taken back up into the nerve ending, waiting on another stimulus to come along and cause its release. Whatever designed us that way so that we'd be driven to eat, so we could sustain ourselves and we would have sex and our species go forward in time. Everybody agrees food, water, and sex are good things, right? Can you think of where food, water, sex may not be a good thing? I'm not going to go down the sex route. I'm going to go down the food route. Until about 5 years ago, I weighed 250 pounds. I tried everything in the world I could to lose weight. Finally, I decided I'm going to watch what I eat and exercise. And I do that every day. I weigh about 195 to 200. That's where I've been for about 5 years. Every morning I work out, 6:15. I work out in a little gym in Mount Juliet where I live called Orange Theory. I love Orange Theory. When I come to Chattanooga, I know where both of them are. I go to both of them in Chattanooga. Okay. And when I work out, I burn 800 calories in an hour. When I come out of Orange Theory, I pass a damn Krispy Kreme donut on my way home. I freaking love Krispy Kreme donut. I want it on my deathbed. Okay. I have this visual image of the donut. I remember how good it was the last time I saw it. I can feel the warmth of the box. I crave it. I'm craving it right now. Right. So when I drive by that Krispy Kreme, what's the reward center in my brain telling me? What's it saying? Pull in there and get a Krispy Kreme. I remember how good it was. Now, what are my goals? To lose weight and get in better shape. So the frontal lobe of my brain, the stop part of my brain, is not about pleasure. It's about insight, judgment, and empathy. It says, hang on a second, Steve. Your goal is to lose weight and get in better shape. Okay. And if you pull in there to Krispy Kreme, each one of those Krispy Kreme donuts are 220 calories and 20 grams of fat. Not a problem. You're going to have 4. It's 880 calories, 80 grams of fat. You just blew your hour workout. You should have stayed in bed. Guys, you all make decisions like that every day. It's about pleasure versus consequence. You're going to do the thing that brings you the most pleasure, that has the least amount of consequence to lead the outcome that you're looking for. The brain is a predictor of the future, and that's how it works. Okay? So I drive by the Krispy Kreme. I'm not going to pull in. My frontal lobe is overwhelmed with my reward system, and now I can reach my goal of getting in better shape and losing weight. Now, here's the deal. The frontal lobe of our brain, the stop, is not physiologically connected to the go system of our brain, the limbic system, until we're 23 years old if we're a woman, 25 years old if we're a man. This is why your teenagers are stupid, those of you with teenagers. They don't have a fully functioning frontal lobe. They don't have insight, judgment, and empathy. We have to teach them that. And as they mature, they get that insight, judgment, and empathy, and their car insurance rates go down. Okay? So that's how this works. And now, for no extra charge, I've taught you about your teenagers. So, Steve, that's well and good. What's that got to do with addiction? These are PET scans of brains. Remember, all PET scan looks and sees where radio labeled sugar goes, right? All the cells in our body work on sugar, one form or another. This top row of brains, normal brains. This second row of brains, it's Brody. Brody comes to me now. Brody is a female, and Brody is pregnant. She's 24 years old, and she's shooting heroin. And she comes into my hospital, and I detox her for 10 days. I said, all right, Brody, you've been detoxed. Have at it. Go back out into the world. This is Brody's brain at 10 days after detox. This is a PET scan. What do you see in the frontal lobe? Nothing. Brody has a fully functioning reward system and all the triggers and cravings that go along with drug use, but nothing in the way of insight, judgment, and empathy. How long does Brody make it in the real world? If you're lucky, the time she takes her to get out of the parking lot. Guys, standalone detox is the most ridiculous thing we do for the treatment of opioid use disorder. It's a waste of time, but it's the thing that insurance companies reimburse the most for. And we absolutely have to change that. Our decisions have to be driven by what we know from a science standpoint. Now, let's look at this bottom row of brains. This bottom row of brains have been detoxed off of drugs for 100 days. I got to stay at CPE in Nashville for 90 days. I'd been in Vanderbilt for 5 days. So I'm roughly at 100 days. Look at the frontal lobe of my brain when I get out. Look what's starting to come back. I'm starting to have insight. I'm starting to have judgment. I've got this group of people around me that are supportive in my recovery. The president of my university, Dr. Paul Stanton, the dean of my med school, Dr. Ron Franks, didn't fire me. They paid me the whole time I was gone. They allowed me to get back into my life. How many of your patients have that? None. None. The patients I have coming to see me today, most of them barely are hanging on with jobs in COVID-19. A lot of them are homeless. A lot of them are living in motels and cars. They don't have these resources. How long does it take to get from the bottom row of brains to the top row of brains? 2 years. That's why I love medication for the treatment of opioid use disorder. Methadone, Suboxone, naltrexone, buprenorphine. Those drugs quell cravings that give somebody a chance to go from this bottom row of brains to the top row of brains so that we can at first help them feel better. Next, we got to help them get better with behavioral change. And then thirdly, we've got to give them the tools they need to be in long-term recovery. So we have to help them stay better. And that's the approach. If you don't remember anything else from my talk, please remember that. So I'll jump through the last part of my talk here really quickly. The second 7 is about trauma. The guy in front of you is Dr. Vincent Felitti. He is the lead author of something called the ACEs study, Adverse Childhood Experiences. He worked at a weight loss clinic in California in the 1980s, working with a lot of morbidly obese women, 500, 600 pounds. And he discovered that one of the drivers for their addiction to food was trauma, physical, sexual, emotional abuse. He developed 10 areas to scale trauma on. They're called adverse childhood experiences. And we know that when somebody gets to an ACEs score of 4 or above, it takes a sharp turn up in their risk for substance use disorder, mental health disorder, diabetes, hypertension, cancer, connective tissue diseases. I think the ACEs study is the most impactful study done in the history of medicine outside of the benefits of washing your hands. And I know that's a big statement, but I can't think of anything that impacts more people than adverse childhood experiences. The screening for that is basically the ACEs questionnaire, which is real easy. We do it for all of our patients, and we have trauma-informed therapists that work with our patients going forward, because a lot of times their drug use is being driven by the emotional, trying to cover up the emotional pain from childhood trauma. I'm just going to touch on ACEs. I want you to be aware of it. That's the second 7 in my screening. The third 7 is just a social opportunity. And here you go. I told you I was going to show you what the pharmaceutical industry used. Back in the day, I told you doctors aren't trained on the treatment of acute and chronic pain. They aren't trained on very much on addiction, the recognition of and referral to treatment for. So who trained them? Pharmaceutical industry trained them. Pharmaceutical companies trained them. And one of the things they trained them on were long-acting opioids. Hey, these things are safer. They don't have as much addictive potential because it's released over a long period of time instead of a short period of time. Your patients won't become addicted to it if you're treating it for real pain. And if they keep asking you for more, it's because you're not properly treating their pain. That's pseudo addiction, which is pseudo crap. No, it's not false crap. That's actually real crap. There's no such thing. And those are the things that they inflicted upon us in the late 1990s and early 2000s. Mainly Purdue Pharma, but spread to other pharmaceutical industries. The studies in the New England Journal that showed less than a 2% chance of addiction, I've actually put on the slide in front of you. The first thing you notice is it's not a study, it's a letter to the editor. The second thing that you need to know was written in 1980. The pharmaceutical industry started using this letter in the early 1990s. Dr. Jick, one of the authors here, from Mass General, didn't even know they were using it. And so they promoted this as evidence that there was less than a 2% chance of addiction. What Dr. Jick and his resident at the time, Dr. Porter, stated was that they simply looked at a longitudinal retro study in Massachusetts. They had 39,000 people in their hospital over a period of time. About 12,000 of them got an opioid preparation of some type while they were hospitalized. They followed them after they got out, and only 2 of them developed addiction. Well, first of all, that's not comparing apples to apples. That's short-term acute pain, not long-term chronic pain. And second of all, it's not a double-blind, placebo-controlled study. The pharmaceutical industry, at the time they used this to promote the drug OxyContin, knew that the addiction rate for OxyContin was somewhere between 15 and 20%. So they completely misrepresented it. And the Sackler family are drug dealers and ties, and should be held criminally responsible and in my opinion, charged with murder for everybody who's overdosed as a result of getting addicted to their drug as they misrepresented it. And that's just me, but I watch it happen every day. I lost 2 friends and patients of mine over the holidays that got started after a surgery or after an athletic injury, and they lost their lives secondary to their addiction over the holidays. So I feel a little more strongly towards the industry than probably the normal person. But now you have all 3 sevens. You have all 3 sevens. You know how they line up. Hopefully I put my story in those 3 sevens so you can see what happened with me. Brody, the good news for you is it turns out that you did not develop addiction, and you went on to become famous in your field of study, so you're good. Your pregnancy turned out well, which I'm sure you're happy with, and you gave birth to a baby that was non-drug dependent. That's another thing. Babies are not born addicted. Babies are born dependent. Why are babies not born addicted? Because they can't have continued use despite consequences. Babies don't do anything. They pee and they poop and they make a lot of noise and they cost a bunch of money. Okay, they cannot have continued use despite consequences. Babies are born dependent, not addicted. Last thing, you look in front of you, it looks like a 10 milligram Percocet. It's not a 10 milligram Percocet. If you want a reason to stay up at night and you have children, this is the reason that you should lose sleep. This looks like a 10 milligram Percocet. All right, it's yellow, it's got Percocet written on it, it's got 10/325 on the bottom of it. Percocet is oxycodone. Oxycodone is 1.5 morphine equivalent. That means that 10 milligrams of oxycodone is 15 milliequivalents of morphine. The problem with this particular one is it's carfentanil. It's not oxycodone. What is carfentanil? It's a fentanyl analog made by the Johnson & Johnson company in the early 70s. It was made to tranquilize rhinoceroses and elephants. It was never meant for human consumption. It is now manufactured in China, brought into the United States through Canada and Mexico, and pressed into pills and adulterated in heroin, and people don't even know they're taking it. So what's the deal with carfentanil? It's 10,000 morphine equivalents, not 1.5. You take this one Percocet that you've been taking every day, 4 times a day, and you take it, instead of taking 15 morphine equivalents, you take 10,000 morphine equivalents, and you die on the spot. You overdose. Guys, illicit fentanyl and heroin is what's killing Tennesseans now. But make no mistake about it, it was driven by the underlying prescription drug addiction. Don't let anybody tell you any different. 80% of the people who use heroin now started with prescription pills, 80. Okay, so we don't need to ease off on our vigilance for being very careful about how we prescribe opioids. But what's killing Tennesseans now and Americans now is illicit fentanyl. The problem is you don't even know that you're taking it. I'm a child of the 80s. My musical heroes of the 80s are long. One of them is Prince. You all don't have anybody today to measure up for Prince, so don't even try. But Prince died of this. Thought he was getting oxycodone from the street. It turns out it was fentanyl. He overdosed and died on the same amount that he thought he had been taking every single day. This is what you're seeing. When you see patients and you drug screen it and there's fentanyl in it, ask them if they know what fentanyl is. Most of the time, they're not even going to know that they're taking it. And last but not least, the most important slide I have. This is my family. This is Florence, Italy, 3 years ago when you could still travel. I see the Duomo in the background. That's yours truly there in the center. That's when I still had a little bit of hair. It's all gone now. That's my son, Heath. That's now my daughter-in-law, Laura. She was not my daughter-in-law at the time. That's my wife, Karen. I want to focus on my right side here. That's my daughter, Haley. In 2004, I thought my life was over. I didn't know anybody could help me. I thought my medical school degree and all my training were down the tubes. I had no idea what I was going to do. I wasn't a good father and I wasn't a good husband. Somebody stepped into my life and saved it and allowed me to live the life to where I took my entire family to Florence, Italy a few years ago. Now, the daddies in the audience that have little girls, sometime in your little girl's life, you're going to know that you're going to have to give her away. It's going to cross your mind and you're going to hate it, just like I did. I hated it every day of Haley's life because I knew one of these days it was going to happen. And every morning of her life, I kissed her on the head before I went to work while she's still asleep to let her know she belonged and she mattered to me and I loved her. And I was going to protect her, and I did. And when she was a junior in high school, she brought this thing here home. And I was waiting on him on the front porch at their first date because I was going to try to scare the little SOB off, okay? And I talked to him for about 5 minutes because she was inside getting ready. And I walked into the kitchen. My wife was in there, and I said, Karen, I think I just met our son-in-law. And my be dang, I was right. A few years after that, I'm standing at the back. I'm in the aisle. My daughter's in her wedding dress, and I've got her on my right arm. And guys, I'm hating it. I'm hating it. I'm wanting to die. I did not want that day to get there. But right before I walked her down the aisle, she leaned her head over on my shoulder and she said, Daddy, you're the first man I ever loved. Thank you for everything you ever did for me. Guys, that day got better in a hurry. That day got really good in a hurry. It's still the best day of my life from a dad's standpoint. But at that moment, the kids don't know this because they haven't heard me do this talk and they don't know I use this picture. At that moment, I knew that I was not 2 dates in the program we handed our guests that night. I was not Stephen Loyd, father of the bride, May 11th, 1967 through October 3rd, 2003. I'm still a dash. I got to give my daughter away that night. Right? The patients that you see that have substance use disorder, this is what they want. Very few of them are sociopaths. They're addicted and they need help. And we don't need to judge them. We need to meet them where they are and give them the tools they need, whatever those tools are, to get into long-term recovery because they want what I want. They want to be a dad. They want to be a father. They want to be a mother. And I'm so grateful that somebody stepped into my life and gave me that opportunity because nobody else walked my little girl down the aisle. I did. I got to do that. And if either one of those, any of those four there ever decide to have children, I'll actually get to be a granddad one of these days. And I look forward to that too. So hopefully what I brought you today was a better understanding of addiction. I wanted to give you a couple of pearls around risk stratifying your patients when you use controlled substances. I focused on opioids, but we need to know about stimulants such as medications for ADD, as well as benzodiazepines. You can use those principles for everything. And I want to give you a little bit better idea, an understanding about people suffering for substance use disorder and kind of the approach to helping them. And with that said, I'll be done. Brody, you were a good sport. Thank you for letting me use you. And I'll open it up to questions, guys. Well, Ray, I guess you guys are there, and I have no idea how somebody would ask a question. They can usually put them in the chat box or anything else, but I don't have anybody communicating with me, so I hope I haven't been talking to myself this whole time.
Dr. Loyd, can you hear me? This is Caroline Hawes.
Yes.
Hi, I'm a second-year pediatric resident. I had a question about your work specific to mothers and children. I've found as a pediatrician in training that the stigma is steep in the neonatal intensive care unit. I'm not generalizing to everyone, but there's steep stigma regarding the mothers of a lot of the babies that we take care of, because unfortunately NAS is very common. And we also as pediatricians worry about the safety of discharging children from the NICU and whether a mother is ready, and not wanting to see that child represent to the emergency room with some kind of non-accidental trauma. I was wondering if you can speak to that briefly. If this isn't a good time for that question, I can just contact you privately. I'm happy to do that too.
Well, first thing, you're always welcome to contact me privately, but I think it's a great time to address this question because there are consequences, and we do have responsibilities for the children that we send home in these instances. What I see is the use of medication stigmatized, and it's mainly because of how you see it used in your community. And Chattanooga is really no different. A lot of people who utilize methadone and Suboxone to help people, or Subutex to help people with opioid use disorder, are fly by night. Their clinics look no different than the pill mills did just a few years ago. They come in one door, they write a prescription, they head out the other end. There's nothing to try to help them from a behavioral standpoint, and that's not what I'm talking about. I'm talking about, as an addiction medicine doctor, participating as part of the treatment team with the pediatrician, with the neonatologist, and for sure involved in prenatal care with the OBGYN or high-risk OBGYN. The truth is that there's very few people out there in the addiction medicine field that are actually doing that, and that's on us, and that's my colleagues, and that's not how I operate. So you have to understand that the treatment of choice for a woman who's pregnant, opioid use disorder, is Suboxone or Subutex or methadone, and that there is a chance that their babies can be born dependent. The goal is they don't relapse during their pregnancy. For the most part, you don't want to taper them or get them off before their birth, although you can if they have the proper supportive environment, and you can start it in your second trimester. So ACOG backtracked on that a few years ago, and we absolutely love to do that when we can and it's appropriate. Otherwise, the medication is appropriate. We need to encourage women who are doing that. They're asking for help, and then we need to help them through the process and not shame them. I've seen women that are so proud of themselves and what they've been able to do with medication through their pregnancy, only to be shamed in the hospital by staff, by nursing staff, by the treating physicians. And it just absolutely breaks my heart. Now, there are things that we have to do to ensure the safety of that child. And a lot of times that we can get our colleagues to help us in Child Protective Services, DCS, but it needs to be framed in a non-punitive way. With that said, there are times that we do have to remove a child from parents' custody for their own safety, and I'm not advocating that we don't. But for the most part, if we do a good job in communication as that comprehensive treatment team, we can actually keep the baby with the parent and build in safeguards to ensure that they're getting started off in the right environment. I'll be happy to discuss it with you more, but one of the things that I'm absolutely killed about is how we treat these women. When I first started getting stories of it, when I first started doing this, I didn't believe the women, and that's my fault. That's on me. And so what I did was I started visiting them in the hospital, and I just wear regular clothes. I'm an internist, so they didn't know me on the OB wards. And I could not believe how they were talked to while they were hospitalized. It absolutely killed me. And so I had two choices. One is go fight, or the other is educate. And so we started educating, and I did talks in the hospital on addiction. I did talks on pregnancy and addiction. We did it around the clock because nurses and hospital staff work around the clock. So we did grand rounds at 7 a.m. We did grand rounds at midnight. We did grand rounds at 3:30 in the morning to make sure that we reached everybody, trying to change their attitudes about addiction. But with that said, there are instances where we still have to remove the child. And I'm not advocating that we don't do that under those circumstances, because we have a responsibility to protect that child once we're aware of it. Hopefully I answered that question, and you can always feel free to reach out to me.
Thank you very much.
You're welcome. So I know we're at 8 o'clock, and I know you guys are medical students and residents, and there are stuff to be done. So if you want to reach out to me personally, my contact information is widely available. The best way to get me is to text, but I will return phone calls and emails. All right, are we good?
Thanks.
Thanks, Dr. Loyd.
Thanks, Dr. Loyd.
You're welcome. Ray, reach out to me with anything, and I really hope that was what you guys were shooting for.
Thank you.
You're welcome.
Excellent presentation.
Thank you.
Thank you.